All right, so this is the December 2022 MEC Minute, and our topic today is the 2023 MEC EMS protocol. And this is a talk we have every December as we transition to the next year and prepare for the next version of our protocol. So what are we going to talk about today? First, a couple quick comments about the ResponseSoft app. We'll talk a little bit about the 2023 protocol assessment. That's something we do every year. And we'll also talk about three major revisions and additions to the protocol for next year. There are not a lot of changes for next year. Much of what we've done is reformat material with no real change in content, but we've made we reformatted to make understanding and compliance with the protocol better. And then we're also going to talk about a couple specific medications and changes that have been made that you as providers need to be aware of. So in terms of the protocol, a PDF copy of the protocol was distributed to all the EMS coordinators in November. So you should have a copy available to you, probably in electronic form. And that protocol is something you should review between now and the end of the year. The protocol will update on ResponseSoft January 1st. So if you have ResponseSoft on your app or on your tablet, and I hope you do, you should open it up when you get back on duty or sometime after the first of the year. You should see a pop-up notice that says there's an update to the protocol. Do you want to download? Click yes, so you have the most recent up-to-date copy of the protocol on your device. And again, make sure you download the update on all of your devices. So if you have a tablet and a phone, update both. And if you have a computer, you can do it on your laptop as well. So, update your protocol so you have the right information available. This slide's a little mistitled. It's the 2023 protocol assessment, not the 22 protocol assessment. It will be distributed the first week of January. I'm starting to work on it now, so if I get it done before the end of the year, you'll see it sooner. But essentially, it's a review of the protocol with questions about the protocol that is in effect after the first of the year. Everyone is expected to complete this protocol assessment by the end of January. It is a pass-fail. If you take it, you pass. If you don't take it, you fail. There is no numeric value that you have to achieve. But the important thing is that you review the assessment and learn from it. Therefore, we really recommend you do this as a group activity rather than sit alone and do it. I like the idea of this being done as a group activity around the lunch table or in some format where as a group, your crew can review the materials. If you're a company officer, I would encourage you to make this part of your training calendar for January 23. And then as part of this, like we do in the past, we're going to have an assessment review and answer video from myself and Dr. Stoner. It'll come out probably early to mid-January, and it's going to be our way of explaining why we think the answers that we've given are the correct answers and to review the questions. We may also hopefully recruit some provider to sit in and give color commentary and ask appropriate questions as part of the discussion. So you should see that show up in early to mid-January. Now, if we're talking about protocol and protocol changes, the protocol changes are really listed on pages 370 to 374 of the 2023 protocol. So when you get your hands on that PDF version of the 23 protocol, go to page 370. The most recent changes are on page 370. And as you go further back on the pages, you'll see protocol changes over the past year or two. So it's kind of a cumulative list of the changes that have occurred. But please take a look at that. Just a brief comment, if you look at the PDF version that we've just distributed, there are hot links available in that, so you can go from the change to the protocol. However, those hot links don't work. When those links work, we'll send out an updated version. But really don't try to go somewhere by clicking on those links. The major changes that we've added are listed here. Rocuronium is back. We'll talk about that in a moment. We're going to use DuoNeb instead of albuterol and Atrovent. Basically, DuoNeb is albuterol and Atrovent mixed together in one vial. We've made some revisions to narrow complex tachycardia and the algorithm. We've done this to reformat and make the thought process work better. It flows better, and we'll discuss that in a moment. We made some formatting changes to unconsciousness and added some things. Due to really fairly Frequent questions. We've looked at our midazolam and ketamine dosing schedule for behavioral emergencies. So if you have a behavioral emergency and the patient's SAT is +1 or +2, and they're still acting out, still need further sedation, you can repeat the dose, but at half the amount. Again, we'll talk about that. We've made some adjustments to PO Zofran to be consistent through the protocol. To a large extent, that's because of the state rules regarding advanced DMTs and Zofran. We do have some advanced DMT providers out there, so we need to keep all of this consistent so that they can administer the medication. You may or may not be aware of it, but since March, we've been doing a pilot with a stroke protocol in Fairfield County where LAMs 4s and 5s are transported to Columbus instead of Fairfield Medical Center. We'll get into the details in a few minutes. And then we've made some other changes regarding our TXA dosing, use of burn dressings, and intramuscular medications. So what about Rocuronium? So Rocuronium has been on our medication list in the past. We took it off with the idea that we don't need succinylcholine and Rocuronium. Rocuronium is a longer acting paralytic. And we looked at our practice style as where all of us are relatively close to a hospital. Why do we need anything more than succinylcholine? Well, we've had some changes, particularly in Fairfield County, where some of the EMS trucks are making longer distance transports. They're driving to Columbus, and the patients are intubated, and succinylcholine provides inadequate paralysis for the patient. Succinylcholine lasts 5 or 10 minutes, and the patient's coming out of it. Rocuronium lasts anywhere from, key effect for 20 to 30 minutes, could be up to an hour. So Rocuronium, one dose, and the patient is controlled until they get to the receiving facility. So Rocuronium is going to be added to the drug licenses for all of our member agencies. However, each agency must make the decision on whether or not they want to put Rocuronium on the truck. And the decision really needs to be based upon anticipated transport times. Rocuronium would be the second drug. The patient is chemically paralyzed with succinylcholine after they get their ketamine, and the tube is in place. You need additional paralysis, then you can give Rocuronium. So you cannot give Rocuronium until the patient's intubated utilizing succinylcholine and you've confirmed tube position. And it's really meant for longer patient transports. So at the bottom of this slide, I have kind of an excerpt of what the new protocol looks like. So, the part 4 is second dose of succinylcholine can be given at 2 milligrams per kilogram. And if available and long transport times are anticipated and the patient is intubated, you can give Rocuronium if the patient requires longer lasting paralysis. So the Rocuronium dose is 1 milligram per kilogram IV push or IO for a maximum of 100 milligrams, which I believe is 1 vial. And you can only use this one time during the transport. You should have adequate paralysis with a single dose of Rocuronium. Keep in mind, Rocuronium is a paralytic. It does nothing to deal with pain. It does not provide any help with awareness. So if a patient has Rocuronium, they must have adequate medication for pain and or sedation. So make sure you use or follow our protocol for fentanyl and Versed to keep the patient well sedated while being transported. I would have no qualms about being a little extra generous on these medications if you give the dose of Rocuronium to the patient, because the patient can be aware even though they're chemically paralyzed. So as part of this, if you are going to have Rocuronium in your truck, you need to be aware of its indications and its use. For us, we use it for adults. We don't have it listed as a paralytic for children. The need for pediatric paralytic, particularly long-acting rock, is very, very low. But for adults, we use it as part of our DSI process. You can give 1 milligram per kilogram IV or IO. The biggest side effects they really have to do with some cardiac arrhythmias, nausea, vomiting, asthma. Sometimes patients can develop allergic reactions. This medication really works pretty quickly. It works within the first couple of minutes of administration, and its duration of action is 30 to 60 minutes. Hence my comment that for EMS transports, one dose should be enough to get you where you need to go. So Rocuronium is now on the pharmacy or the medication list, the drug license starting next year. It's up to your EMS administration to determine whether or not you are going to put it on your trucks. And that has to be discussed on a department by department basis. So talk with your EMS coordinators if you have any questions or concerns. If you are going to use the medication, you need to be aware of its indications, contraindications, route of administration, dosing schedule, etc. So if you're going to have this medication available on your truck, look at this page, make sure you read it before you use the drug for the first time. DuoNeb and magnesium. I kind of threw magnesium on this slide just as an add-on. But DuoNeb is basically a single mixture of albuterol and Atrovent. So as part of our current process for bronchospasm, we use albuterol, an ampule of albuterol plus one of Atrovent, mix it together in the acorn, and we nebulize it for the patient. Well, we're going from 2 different vials to a single vial that's got both medications. We basically went into the protocol and substituted DuoNeb for every indication in the pediatric and adult protocols. So if you have a patient who's bronchospastic, a patient with COPD, any patient you think needs a bronchodilator, what we use is going to be DuoNeb. Other than medication substitution, changing the words albuterol plus Atrovent to DuoNeb, there is no change in our protocols on how this medication is administered. So you just think, okay, instead of pulling out 2 different vials, you're going to pull out 1 vial. The one thing we will do, though, is we don't expect all agencies to take their current supply of albuterol and Atrovent and throw it away or give it away. You can use up what you have, and then you can use the DuoNeb after that as the new medication. So hopefully you don't have 2 years worth of albuterol and Atrovent in your storeroom. You can, as the medications either get used up or have to be replaced because they have gone past their expiration date, you can use up the supplies you have. Another thing, just since we're talking about bronchospasm and treating bronchospasm, magnesium sulfate is in our protocol for bronchospasm, for cardiac arrhythmias, and for eclampsia and preeclampsia. So in the protocol, magnesium sulfate is the wording is being changed from 2 grams IVIO to 2 grams and 100 cc's of normal saline over 20 minutes. This is for every indication for magnesium except cardiac arrhythmia. So if you have a patient with torsades, you pull up 2 grams in a syringe, you give it IV push. If you have a patient with refractory VF and you're going to try mag sulfate, you can pull up 2 grams in a syringe, you give it IV push. All other administrations of mag sulfate is 2 grams or 4 grams for the eclamptic patient in 100 cc's of saline infused over 20 minutes. So that's the only real change regarding magnesium sulfate. But you have to be aware of that. It was not very clear in the previous iterations of the protocol. Narrow complex tachycardia. So I have here on the left the whole new algorithm for PSVT, and on the right I cut out the bottom part of the algorithm so you can see it better. If you think about our current protocol, atrial fibrillation sits under the PSVT box, so you have to go through the PSVT box before you get to atrial fibrillation. We just made them 2 different branches. So if the patient is in atrial fibrillation with RVR, you go to the box on the right. If the patient's in PSVT, you go to the box on the left, which is adenosine. If the patient is unstable hemodynamically, either way, you cardiovert. So we just made a change to formatting. In terms of content, there is no change. It's the same medications for the same indications. It's just we have 2 branches coming off stable instead of 1. So that's the only change you'll see. So hopefully this makes things clearer. It was a great idea. We got this through the Protocol Education Committee to make this change. I think this really makes more sense now. If we're talking about unconscious or unknown patients, in the past protocol, it's called unconscious unknown. We've changed it to unconscious and syncope. So you get on scene, either somebody is unconscious or they had a syncopal episode and now they're awake. We went to kind of 3 branches of this now based on the blood sugar. So if the blood sugar is less than 60 on the right-hand side, the most right-sided branch of the algorithm, you follow the hypoglycemia protocol. Glucose less than 60, you give them dextrose, or you give them glucagon if you can't get access, or you give them something orally if they have a good gag reflex and they're able to swallow. If the patient has a acceptable glucose, then they were either unconscious and they're still unconscious when you get there, in which case you treat with naloxone and thinks about other potential causes of loss of consciousness. Or the patient was unconscious, EMS was called, and when you arrived, they're awake, in which case, for our purposes, they had a syncopal episode. If the patient had a syncopal episode, they get a 12-lead EKG. We should be always getting a 12-lead in the field on a patient who's had a syncopal episode, because we don't know if they have an underlying cardiac arrhythmia that may have contributed to it, or if they have a STEMI or something else. So patient passes out, they're awake and alert on the time of your arrival, get a 12-lead. The other thing you should be doing is a stroke screen as well as orthostatic vital signs. So does the patient have any focal neurological findings? Do a quick LAMS or FAST exam. If the patient's able to stand, do orthostatics. What's their blood pressure down? What's their pulse rate down? What's their blood pressure and pulse sitting up or standing up? Those things are important. And I think it's important to get them in the field because, if you find them orthostatic in the field, give them a 500 cc bolus of saline, they may no longer be orthostatic by the time they arrive in the emergency department. So it doesn't take long to do, just get it done. In terms of a patient who's still unconscious, try the naloxone. It doesn't work. Think about other potential causes like stroke and overdose. You may also consider getting a 12-lead EKG on those patients as well. But again, we're differentiating between patients who are unconscious versus syncope versus hypoglycemia. And all patients with altered LOC get a finger stick. So something to keep in mind. Behavioral emergency. So we've had the behavioral protocol in place for a good number of years. Recently, in the past year or two, we came up with a shared protocol with other EMS agencies. We've had some experience with this protocol now utilizing the sedation assessment tool, or SAT. And based on the SAT score, we administer medications. So I heard feedback from our providers that, hey, patients in SAT 1, SAT 2, we give them a dose of medications as called for. They still don't have adequate response. They're still having an acute behavioral emergency. They're still unsafe to transport or difficult to control. Can we give them more medication? And, after thinking about it, I think it's a good idea. You go back and you do their assessment, and they come back as an SAT 1 and they're still agitated. Well, you can give them the same medication you gave, but half the dose in 10 minutes. So midazolam and ketamine are both very quickly absorbed. Midazolam, you should see an effect of midazolam IM within 5, if not 10 minutes. So if they still need additional medication, then I would give them half a dose of whatever you gave the first time. And that should give you adequate control of the patient. So if you had a patient with an SAT of 2, you gave them 10 milligrams intramuscularly of midazolam, and they're still agitated, still carrying on, I would give them half the dose of the original dose, which would be then 5 milligrams of midazolam IM. This doesn't happen often, but it does happen. And in order to keep our crew members and our patients safe, I think it's a reasonable thing to do. So half of whatever you gave in 10 minutes if they have ongoing problems. Next up is just PO Zofran dosing. So we're only talking about oral Zofran, and the reason we're talking about it, again, is because we have advanced EMTs, and they can give oral Zofran, but the dosing schedule for advanced EMTs is specifically spelled out by the MFATS board. So advanced EMTs cannot give IV Zofran, so there's no change to dosing schedule for IV Zofran, whether it's adult or children. If we're talking about PO, then the child has to be at least 20 kilos, and you give them 4 milligrams PO. And really, if you look at the rules for the medical board, the MFATS board, it's 20 kilos and 12 years of age. So if you have a child who's 20 kilos and 8, they can't get oral Zofran. They can get IV if you have access. It may seem a little screwball in that why do we have, you can give kids of almost any age IV Zofran but not PO? Well, it's because we've got advanced EMTs, and I really don't want to have 2 different dosing schedules for an oral medication based on the credentials of the provider. I did notice as part of this, you look at the bottom of the box where it says no dosage for less than 40 kilograms. That should be for less than 20 kilograms. I'm going to have Gordon Griggs fix that. So we need to work on that. But this is really meant to clarify it, and we've made changes throughout the protocol, whether it's the abdominal pain, the medication information sheet, so on. There were some inconsistencies there, and we've fixed them. I want to talk a moment about the Fairfield County Stroke Protocol. We had a protocol as a pilot project starting in March to look at transport destinations for stroke patients, principally those EMS agencies that transported patients to Fairfield Medical Center. This protocol was developed at the request of the chiefs and EMS coordinators of those agencies. So this is not something I came up with. This is something we developed in response to a request from EMS leadership. Fairfield Medical Center is a primary stroke center, which means they can rapidly assess stroke patients, administer IV thrombolytics, and then if the patient has a large vessel occlusion, refer the patient to Columbus for intervention. So what we did as part of this protocol was if the patient's a LAMS 1 to 3, we take them to Fairfield Medical Center. If the patient is a LAMS 4 or 5, they are transported to the closest comprehensive stroke center, either via air-evac, which is parked in the backyard of Pleasant Township, or ground vehicle. I know the Lancaster medics often go up 33 in their medics, and they get the patients to Columbus quickly. You know, the closest comprehensive stroke center is Mount Carmel East, the other two being Ohio State and Riverside. But just so that we don't seem like we're advocating for a specific facility, the protocol just says closest comprehensive stroke center. The medics know which one's the closest. So this protocol really did well. We've had some great outcomes with it. So we're no longer keeping it as a pilot protocol. This protocol is being moved into the EMS protocol the first of the year. So I think the pilot showed success. So it's going to be out there. If the patient has a LAMS 4 or 5 and the crew can get to Columbus by ground quickly, that's the option. If they think flying is faster, then air-evac is available. And it's up to the medic to determine what is the quickest route. So either air-evac or ground. The Lancaster crews are getting to Mount Carmel East in about 30 minutes, which is our goal. Now, if there's bad weather, then the helicopters aren't flying. And if the weather's bad and 33 is a mess, there's no sense in trying to get to Columbus, go to Fairfield Medical Center if weather precludes safe driving up the freeway. Other changes, we made some other changes within the protocol. So recently, the TCCC, which really has to do with trauma care and EMS, it recommended increasing TXA dosing in the field from 1 gram to 2 grams. So, excuse me, in the protocol, we have increased the dose from 1 gram to 2. Same indications, same route and timing of administration. So the only difference in terms of TXA is if you think the patient needs TXA, they get 2 grams instead of 1. You take 2 grams, put 100 cc's of saline, infuse it over 10 to 15 minutes. So nothing's changed except the dose. In the past, we've had EMS providers use gel dressing for burns. We have experienced where patients do well with it. In June, when West Licking had their training session out at Station 402, one of OSU's burn surgeons was there, and I asked her about use of gel dressings. And her suggestion was that we only use them for body surface area burns of 10% or less. Patients do receive comfort, but with patients with bad burns lose heat. So we don't want to put on a dressing that's going to cause the patient to become hypothermic. And the burn surgeon's feeling was, if you start putting these dressings on anybody with a BSA burn over 10%, the risk of hypothermia goes up. And the other thing about this is be careful in any other circumstance where using this dressing may result in significant heat loss. And I'm thinking mostly wintertime. So even if it's a 5% body burn, if you're out in the cold and you're stuck outside for 10 minutes, putting this dressing on can have the potential to induce hypothermia. So be very careful using burn dressings, the gel dressings, for patients when it's cold outside, regardless of the amount of surface area that's involved. So they're out there. They'll be in the protocol. You may start using them the first of the year. And then the last changes that we're making throughout the course of the document is, medications like dexamethasone, which is Decadron, Narcan, and Benadryl, can all be administered intramuscularly, and we're making adjustments to the protocol to indicate that. Some of these medications are listed as you can give it PO or IV or IO, but not IM. Narcan more and more in many EMS agencies are beginning intramuscularly rather than intranasally. It's still very effective. So you can use IM route of drug administration for these medications now. So we're going through modifying, making sure we got it covered. The last thing I want to talk about has to do with anticipated changes in mid-2023. We have a couple projects out there that are slated for start sometime mid-year. I know you've all heard about the heads-up CPR. We did the Eligard trial. Does not look like we're going to purchase the Eligard devices, but I think we should move to heads-up CPR. Prairie Township on the west side of Columbus has been using a PT wedge to elevate the head over the past couple of years, and they've had good success with it. So the Protocol and Education Committee has been charged with coming up with a protocol as well as a training program for heads-up CPR. I anticipate that process will be implemented July 1st. With that comes training, and I expect that April, May, and June of next year, we will spend a lot of time and effort in terms of training on heads-up CPR and how you transition from patient being flat to the patient on a PT wedge, and how you use the Lucas and everything else. So the process is simple, but training will take time. The second thing that we anticipate is there's a big push in Central Ohio to transition from smart triage system to SALT. You may have heard about it. Dr. Command from Ohio State has a virtual reality program to train on SALT. SALT is an easier triage process, and what people like about SALT is controlling massive hemorrhage is at the top of the list, whereas in other triage protocols, hemorrhage control is further down the list. So many places now, in terms of shootings and mass casualty episodes, their first priority is stopping the bleed, and airway is secondary. So SALT has a lot of emphasis on hemorrhage control. So you'll see more of that. I don't have an exact timeline, but I anticipate sometime in the first half of the year we'll make a transition. So that's it for the protocol changes. Thank you. Thank you for your attention. It's been a good year for us. Thank you for everything done for your communities and your patients. Please make sure you review the Rocuronium information sheet if your agency is going to have Rocuronium on the trucks if it gets added to the drug bags. If you have any questions, please post them on Basecamp. Otherwise, please have a happy and safe holiday. Happy New Year's. I hope you have the best. Thank you.